parts of their vision are missing. A very useful thing that I do when I explain this to patients, because as I said earlier, patients don't see a big black blob in their vision, but sometimes I will sit right across from them, cover up one eye, and have them cover up one eye, and I'll do the same and have them look right at my nose. And if I know that they have a dense arcuate scotoma in the upper visual field, I'll ask them, can you see the color of the hair on the top of my head? And they'll say, no, I can't really see the top of your head. And sometimes that's the very first time the patient is aware that there are parts of their vision missing, and that is very powerful in explaining to patients that they really are losing vision. The grayscale up above and the probability plots may not agree. So here's a patient who has an arcuate scotoma or a partial arcuate scotoma down below, and the grayscale is not showing much of anything. So it's important not to use. Patients ready? Okay. That was quick. They turned over the room very quick. Okay. So this is the most useful aspect of automated perimetry, is looking at the total deviation and the pattern deviation. And you want to look at the depressed points in terms of not jumping on a single individual point, but looking overall at the pattern and how severe the loss is. The global indices, you have the mean deviation, we've already covered this, and as well as the glaucoma hemifield test. What the glaucoma hemifield test does is it compares the upper part of the field to the lower part of the field and asks the question, are they symmetric? The areas where the glaucoma hemifield test looks for, and you had a similar test on your machine that I saw here, and it mirrors the distribution of axons coming off of the optic nerve. So here you have a patient who has dense field loss up above and not so dense field loss below. And when that respects the horizontal midline, that is very typical in nasally of an early glaucomatous field loss. So the glaucoma hemifield test can give you 3 answers. I don't know about your machine, but it'll say that it's outside normal limits, borderline, or within normal limits. And this, as it's explained in the screen here, when it's outside normal limits, that degree of asymmetry between the upper part of the field and the lower part of the field is present in less than 1% of the population. Rule number 4 is to look for a nerve fiber layer pattern of field loss. And here you can see a classical arcuate scotoma that looks like a bundle defect. And here you can see the glaucoma hemifield test is calling it as outside normal limits. The mean deviation and pattern standard deviation are all consistent with this being a glaucomatous visual field defect. Here you can see the defects can be very, very small right near the center. And I forget the gentleman who was asking me yesterday about patients with glaucoma with relatively low pressures. One of the hallmarks of glaucoma with low pressure is often that they have very small but dense paracentral defects right near their fovea. And cataract can obscure visual field loss. You can have a total deviation that's quite severe because of cataract, but when you then look at the pattern standard deviation that corrects for this, you can then see that there is in fact an arcuate defect that is still present. Here is nasal loss, which is typical for glaucoma hemifield test, is calling it borderline, but this is worrisome, especially if there are changes in the optic nerve that correspond to this. So here's the patient over time getting slowly worse. Again, a patient getting slowly worse over time. So lastly, you want to reaffirm the diagnosis, and what you want to do is, once you've done these 4 things, checking that it's the right test, checking the reliability, checking whether or not it has the overall global indices as well as the retinal nerve fiber layer pattern, then you want to reevaluate whether or not this is consistent with what you're seeing in the optic nerve. So here's a patient, and this is an important thing, and I'll talk about this tomorrow. Never ever make a decision based on a single visual field. In the ocular hypertension treatment study, where we were evaluating patients who started off with normal visual fields, 86% of the time, when we retested them, if they had their first visual field defects, the next time we tested them, the visual field was normal again. So you should never make a decision to do surgery on somebody or start them on medicines if you're not terribly worried about them based on a single visual field, because more likely than not, when you retest them, it's going to be normal again. So again, you can have substantial damage in early glaucoma and moderate glaucoma. You can have a lot of damage before the patient shows up with visual field loss. So here this patient already has a bit of a notch. It gets worse and you can finally start to see visual field loss getting worse. But the patient clearly has damage here, and yet they have no field loss here on the right, on the left rather. So let's do a couple cases, and then they are calling us to the OR to do surgery here. This is a 57-year-old man who comes in for a routine exam. His pressure is 22, he has excellent vision, he has a small disc size and almost no cup, and yet what we see here is a visual field that was done correctly. So everything is done. His age is correctly entered into the machine. The reliability is quite good. His probability plots show some nasal loss that's certainly consistent with glaucoma. And it is a nasal step pattern, again consistent with a glaucomatous field loss. And so we reaffirm the diagnosis as being most likely glaucoma, early to moderate glaucoma. Let's look at another patient, a 58-year-old man who was seen 9 years ago. His pressures have been in the mid-20s. His visual field is normal, and he presents for follow-up, and he's an ocular hypertensive. Let's look at those nerves again and confirm the scleral ring. This is an average disc size. He has some inferior rim thinning. There's some diffuse retinal nerve fiber layer loss. He has some peripapillary atrophy around the optic nerve, but there's no hemorrhage. And this patient has glaucoma. Now let's look at his visual field. Remember he had inferior thinning of the nerve. The test is done correctly. It's a reliable test. His probability plots show significant loss nasally, and this is consistent with a nasal step. The glaucoma hemifield test is calling it as being glaucoma. And we can reaffirm the diagnosis by correlating the optic nerve appearance to the visual field. And this again corresponds to glaucoma. So let's stop there, and I'm going to go ahead and just give you just two comments. We're going to go back and do surgery on the first patient. We'll be doing a Barvelt implant, which is a glaucoma drainage device. And I'm eager to show you how that technique works, and I'll be talking and answering your questions back here. Thank you.
So while we are waiting for them to set up the OR, we'll give you a 5-minute break, and then come back again for the next lecture.